For your patients with hard-to-control hypertension, are you struggling to achieve blood pressure goals despite treating with at least 2 antihypertensive medications? Uncontrolled hypertension increases the risk of death and stroke for many patients. Not all hypertension is the same. For many of these patients, you may want to consider a different pathway. Aldosterone may be to blame. Visit blamealdo.com to learn more.
Big news, CardioNerds! AHA Scientific Sessions 2025 is now 4 full days. Get more late-breaking science, immersive learning, and meaningful connections. Don't miss core cardiology programming, 21 education communities, and guideline-focused sessions. November 7th through 10th in New Orleans. Register now at scientificsessions.org.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey CardioNerds, this is Amit Goyal. Welcome back to the CardioNerds Narratives in Cardiology series, led by CardioNerds Academy Program Director Dr. Gurleen Kaur. This series of episodes is designed in collaboration with the AHA Women in Cardiology Committee, with mentorship from Drs. Monica Sanghavi, Pam Taub, and Renee Palmer. I hope you enjoy this first in a series of episodes to celebrate the evolving role of inspiring women leaders in cardiology.
Welcome back, CardioNerds. I'm Apoorva Gangavelli, an internal medicine resident at Emory and a CardioNerds Academy Fellow. I'm so thrilled to be co-hosting this very special episode with Gurleen Kaur and Jenna Skowronski. Today, we're diving into a topic that's personal, timely, and deeply impactful: the representation of women in advanced heart failure and transplant cardiology. This episode is the first in a collaborative series with the AHA WIC Committee, led by Dr. Monica Sanghavi.
Thanks so much, Apoorva. It's so great to be here with you today. I'm Gurleen Kaur, a cardiology fellow at Brigham and Women's and CardioNerds Academy Program Director. It's so exciting to be here with such a phenomenal group of people to discuss such an important topic. And we know that despite women's foundational roles in shaping the field of cardiology, heart failure, and transplant cardiology, women remain underrepresented in leadership, research authorship, and fellowship training. And today we're joined by 2 really inspiring leaders in the field to explore how we got here and where we go next. And I'll turn it over to Jenna to introduce herself as well as our guest speakers tonight.
Thanks, Gurleen. Hi, everyone. I'm Jenna Skowronski, an advanced heart failure and transplant cardiologist, joining faculty at University of North Carolina, and I'm also chair of the CardioNerds Heart Failure Council. I'm thrilled to be joining Gurleen and Apoorva as we shine a light on the legacy, challenges, and future of women in heart failure cardiology. It's an honor to introduce Dr. Mariell Jessup. Dr. Jessup is the Chief Science and Medical Officer of the American Heart Association, past president of the AHA, and emeritus professor of medicine at the University of Pennsylvania School of Medicine. She practiced heart failure and transplant cardiology for 30 years at the Hospital of the University of Pennsylvania, where she served in a variety of administrative roles, including medical chief of the Heart and Vascular Program and clinical chief of cardiology. Her visionary leadership and commitment to heart failure care and equity have shaped our field. Dr. Jessup, welcome to CardioNerds. We're so glad you're here.
Oh, well, thank you for such a really kind introduction, Jenna, and I'm thrilled to be with you all.
We're also really thrilled to welcome Dr. Nosheen Reza, Assistant Professor of Medicine at the University of Pennsylvania and a leader in advanced heart failure and transplant cardiology. She is a fierce advocate for diversity in cardiology and co-author of the 2021 Cardiac Failure Review article titled Representation of Women Physicians in Heart Failure Clinical Practice. She's been such an instrumental mentor for us at CardioNerds, including our prior Narratives in Cardiology series. And CardioNerds will also remember her from her teaching on the hemodynamic evaluation of cardiogenic shock on episode 172. Dr. Reza, we're so excited to have you on CardioNerds again.
Thank you so much, Gurleen, Jenna, and Apoorva. Many thanks to you and the CardioNerds community for welcoming me back and the invitation to join truly one of my heroes, Dr. Jessup, for this very important conversation.
Before we dive into our first question, we want to take a moment to reflect on the rich history of women in advanced heart failure and transplant cardiology, which is beautifully captured in a timeline published in the Cardiac Failure Review. From the pioneering work of Dr. Sharon Hunt and Hannah Valentine in the 1970s and 1980s, to Dr. Margaret Billingham becoming the first women president of the International Society for Heart and Lung Transplantation in 1990, women have helped define this field. Dr. Hunt's call for specialized training in transplant cardiology in 1995, and Dr. Lynn Stevenson's landmark publication on hemodynamic profiles in 2003 laid critical foundations. The Heart Failure Society of America advocated for subspecialty recognition in 2004, with advanced heart failure and transplant certification finally being approved by the ABIM in 2008. Dr. Jessup herself chaired the 2009 guideline writing group and later was named president of the AHA in 2013. Since then, we've seen more women ascend to leadership, including Dr. Joanne Lindenfeld at the HFSA and Dr. Mary Noreen Walsh at the ACC. Still, representation remains far from equitable. What brings us to today's conversation? Let's start by going back in time. Dr. Jessup, your name appears prominently on the timeline of key moments for women in heart failure. From co-authoring the heart failure guidelines to leading the AHA, can you walk us through your own path? What inspired your journey into advanced heart failure and transplant? And what was it like as a woman navigating the space in the 1980s and 1990s?
Well, thank you for that nice review. There are two things that are important when we start talking about past history. One is that when I was a fellow and even a young cardiologist attending, there wasn't anything like a heart failure transplant specialty. I mean, there was no heart failure cardiologist. There were interventional cardiologists and there were electrophysiologists, but the field of heart failure really wasn't defined. Then there are a couple reasons. One is there was no treatment for heart failure. When I went as a fellow to Penn, the investigational studies that we were doing, the patient background therapy was digoxin and Lasix. And so because there wasn't any treatment for patients with heart failure, we were inventing it as we went on. And my mentor, Dr. Carl Weber, was literally instrumental in defining so many things that we think about as standard now, particularly V.O2 max, and thinking a lot about renin-angiotensin, aldosterone access. Those were all things that were brand new and exciting. So that's one thing that's really important to keep in mind, that the reason women were in this field is that there really wasn't a field, and there just happened to be a lot of women that were bringing it along and there at key times. The second is that with respect to transplant, I mean, this was a field of surgery. I mean, it was the surgeons that were doing all of these things. And I always call it the begots. You know, the surgery program at Stanford begot all the other surgical programs. They went out and prospered and went to different hospitals. And for a long time, pretty much everybody practiced the way Norman Shumway practiced, which was based on a surgical approach and doing the biopsies and managing the immunosuppression. It was Sharon Hunt, because of her extraordinary clinical ability, who worked side by side with Norman Shumway, and he recognized that there needed to be a medical aspect of it. And so I don't know why it was that there were a group of us women that sort of evolved to be standing next to a bunch of surgeons who, all intents and purposes, were men. But that's the way it was. And in the early days, we just thought it was interesting that there were so many women in really, the medical area of transplant. We didn't think of it as that we were doing anything pioneering with respect to our gender. We thought that we were doing something pioneering and that we were beginning a field of the medical aspects of heart transplant. But of course, as things went on, as we were developing transplant, simultaneously new medical therapies for heart failure developed. And I think that was the beginning of where we maybe lost our dominance, because so many of the early women that were in the field of what we called heart failure were really transplant doctors. And there were some key people that came out of the VA system in the United States. So they were almost all men that were really controlling and dominating the development of new drugs for heart failure. So we were almost on a parallel path. So I think that that's what's interesting. And that's why, for instance, the Heart Failure Society of America, even though we say, well, gee, there were so many women, but it was in the field of transplant. And the Heart Failure Society started out with the same group of men that were very dominant in the field of new vasodilator therapy and then ACE inhibitors, et cetera. So I think it is interesting to look back on that and realize that we grew along in kind of parallel paths of heart transplantation and medical therapy. And it was not probably until sort of the 1990s that we began to realize we were all on the same team then. But by that time, it was a field where more and more people were coming into it. And just by sheer numbers, women were overshadowed by the number of men.
Dr. Jessup, thank you so much for sharing that. It's fascinating for me as somebody entering this field to get to hear your experience and kind of the genesis of a lot of it. I also think it's important to say that as a woman who is entering my early career, women like you and Dr. Stevenson and Dr. Lindenfeld that were mentioned kind of have normalized women being in the field for us younger folks. So I think it makes me have a lot of gratitude for it, that normalcy that you've gifted us because of all the work you've done. So thank you. Dr. Reza, as an early career leader in the field, how do you feel and how do you reflect on the legacy of pioneers like Dr. Jessup? And how have these milestones, like the creation of the advanced heart failure and transplant cardiology subspecialty, or the impact of women as society presidents, shaped your own experience and ambitions?
Yeah, Jenna, I think what you just said actually hit the nail right on the head. I think the path that Dr. Jessup and so many other women leaders carved over the last few decades has truly shaped what's possible for our generation. And I think, as you heard, very sort of succinctly but beautifully summarized by Dr. Jessup, first and foremost, she was talking about, and what I have witnessed in these women's careers, is this commitment to patient-centered care. Unwavering and relentless. And then on top of that, you add their commitment to training the next generation, mentorship. All of that has laid a foundation for people like us to envision ourselves not just practicing in this field, but going on to shape it and driving it. And moreover, in our review article that we were talking about earlier, and as you all recited in the opening segment, our subspecialty of cardiovascular medicine, I think perhaps more than any other, has been truly trailblazed by these incredible women cardiologists who've been at the forefront of advancing heart failure research and care. I think the creation of advanced heart failure and transplant cardiology as a recognized subspecialty, and now I would say even undergoing a sort of renaissance in and of itself with the entree of device therapies, cardiac critical care, all of these are major steps forward in professionalizing and elevating this discipline. And Jenna, just as you mentioned, seeing women at the forefront of that effort is obviously inspiring and motivating. But of course, with that inspiration, for me, also comes a call to action to build on this legacy with a vision for an even better future for our workforce and, of course, for those for whom we care.
Thank you, Dr. Reza, for sharing your reflections. And you have been such an inspiring leader that I've always looked up to. The first time I actually attended an AHA conference was as a second-year medical student. And I remember you leading so many of the AHA Fit sessions when you were a fellow at that time. So it's always so great to have people in cardiology in the field to look up to and to really embody that leadership and really give it on to the next generation. And according to your article, we know that women comprise around 26% of advanced heart failure and transplant cardiology fellows, which is greater than many other cardiology subspecialties, but still they're rarely senior authors or steering committee members in heart failure trials. Why do you think these disparities persist even in a subspecialty where women have made such foundational contributions?
Thanks for your very kind words, Gerline. I talked with you a lot, but I don't think you've ever shared that story with me. It's very meaningful. So it's a great question, and one obviously that we grapple with in the review article, and many of us who write and think about this field think about a lot. We've talked about, and even on various CardioNerds podcasts, we've talked about the residency to fellowship cliff. Overall, the term that's referring to, though, that women comprise half or more than half of internal medicine trainees in this country. We are still seeing 20 to 25% translation to cardiology trainees, and then fellowship to advanced fellowship, another cliff where, again, we see fewer women choosing to pursue largely the procedural specialties. And advanced heart failure has always really stood out from, for example, interventional cardiology and electrophysiology in terms of, as you mentioned, a higher composition of women trainees in this field that hopefully do eventually translate to women cardiologists in heart failure and transplant cardiology. And there are many people who we talk about the reasons why this may be. I think the conversation we're having today is a testament to why that may be. As we've already talked about, we have great role models and trailblazers in this field. But as you mentioned, even though we have the numbers, we don't have the outcomes in terms of leadership in the field, in terms of both clinical leadership positions and research leadership positions. So despite women's very strong clinical and academic contributions in heart failure, we still face these substantial disparities. You mentioned with regards to research leadership, so I'll focus on that. And many studies from our group and collaborators have shown that both within and beyond cardiovascular medicine, women experience lower likelihood of academic promotion, less recognition for equivalent scientific work, fewer opportunities at scientific meetings and other opportunities to disseminate their science, underrepresentation on traditional vehicles for scientific dissemination like journal editorial boards. All of this translates to decreased visibility and consideration for leadership positions in cardiovascular clinical trials. In addition, there's, as we've discussed and will discuss, lack of targeted mentorship, sponsorship, and institutional cultures that don't always align with career flexible options that we know benefit women. And then, of course, there's a persistent bias in how leadership potential is perceived and nurtured in women as compared with men. So until we address these largely structural inequities, we risk losing talent that could otherwise thrive and lead our field of heart failure.
Dr. Jessup, what structural barriers have you observed, whether it's in mentorship, institutional bias, or lack of visibility, that limit women from advancing into leadership?
I've been reflecting on that question for a couple days now, and it's sort of like the opening sentence of War and Peace. You know, happy families are all alike and unhappy families are unhappy in their own particular way. I think each woman is a different story about, what more I could encourage them to do. So I think, and it's not that I'm blaming them, like in every other situation where there's a disparity between women and men, women have to work that much harder to be acknowledged and recognized and elevated. And so I think that when I see a young woman in our field, I begin to explore what is it that we have to work harder on. And I think one thing that we all need to do, and there are a number of men in very high leadership positions that have all done the same thing. They've gotten a professional coach and they have learned how to dress for success. I know that's like such an old concept, but it's still true. They have learned how to speak properly. They've learned how to answer questions properly. They've learned how to not develop overly complex slides, but really use their force of their knowledge and their personality to explain things. And I really think that is very key. So if anybody, and this is something, it's so powerful that my friend Aldrin Lewis, who is chairman of cardiology at Stanford, he went through it when he moved to Stanford from the Brigham. And he said it was so successful for him. And he was like a butterfly that came out of a cocoon. And it was so successful for him that now when he sees someone in the division that particularly has a lot of great characteristics but doesn't seem to be flourishing, he gets them a professional coach too. So that probably has to do with the area of being invisible or unseen. So as just a real, and you're probably rolling your eyes when you hear me say this, because one time I told a trainee that it was time for her to update her look, and she never had to talk to me after that. But she needed to update her look because people weren't taking her seriously, and people would talk about her behind her back. And that's not a good way to move forward. For instance, it's all right for me as an old lady to wear a navy blue suit that allows me to sort of blend into the furniture. But if you're trying to be seen and heard, then you really do need to wear something that's going to make people stand out. Now, that doesn't mean a really short skirt or a plunging top, but it means to bring something other than a black or navy blue jacket so that people say, oh, wow, well, look at that. And then they listen to you. So that may seem really unconventional as advice, but I feel strongly that it's important so that you don't disappear in the crowd. I also think that if somebody's not stepping up to mentor you, then you need to go choose somebody that's going to help you and be persistent. When I was at Penn, we didn't really have a formal mentorship program. I hope it's better than when it was when I was there. And yet the children's hospital right next door had a very formal program where you had to have sort of a mentor in your own field. You had to have a mentor within the hospital. And then you had to have a mentor within the hospital that wasn't in your field. And she went out of her way to make sure that the meetings happened on a regular basis. And she was fearless in front of all of us, all three of her mentors, to go through each one of her papers, each one of her lectures, each one of her ideas. And, we were constructively critical of things that she was doing. Like we said, why would you say yes to this committee? What were you thinking? Why is that going to help your career? Why haven't you written a paper and you've submitted 6 abstracts? Why aren't any of those converted into papers? And so she really thrived in that environment. It would have terrified me at her age if I'd been at her age, but she really thrived in that. And I think that's important to do. So it's easy to talk, oh, you need mentor, but you need somebody that you're going to listen to and believe in, and they need to help you evaluate everything you're doing on a critical nature. So I think that there's probably many reasons why women don't become as successful as they should. I want to end by saying, however, that I think times have changed. There are so many times where people reach out to me and say, I need the name of somebody good in heart failure transplant. And I'll say, well, what do you want them for? Do you want them to write for you? Do you want them to speak? What do you want them to do? And they'll say, I want somebody, that's going to get in here and get in a long-term project and really produce and has got some good ideas. And that's what I can do to help that person. But then that person has to do that. That person has to then go ahead and stick to the long-term plan and bring her ideas and write the papers. So too many people kind of sit around, and again, I sound harsh, but the mistake is like, why aren't people asking me to do things? Well, what did you do the last time somebody asked? So I think it is not fair that we have to work so hard when we may see our male colleagues not working quite as hard as we think we are. On the other hand, we can't change that, but we can change that when somebody asks us to do something, we do a really good job and that we constantly try to improve how we're doing things. It's a long answer. I'm sorry.
No, that was great. Thank you, Dr. Jessup. And I think as women, we sometimes don't view extra coaching like a professional coach, perhaps not as something that can be used as a tool, but as a failure. And that's a mindset shift that we need to have. I appreciate your insights. They're so wonderful. And I think you kind of hinted at this. There is a very heterogeneous experience for women in cardiology. And while sometimes, we can be in an environment like I have been lucky to be in where we feel kind of part of the culture and very welcome, sometimes the culture can be very unwelcoming. You mentioned some things that we can do as women that can lift ourselves up. But when you think about specific cultural shifts, something that comes up a lot are microaggressions or compensation gaps. How do you view things that need to shift kind of with more of a cultural view to have heart failure be a more inclusive environment?
I'm going to say something politically really impolitic, but I think that if you're part of an organization and it's consistently ignoring women, and I will say, like the Heart Failure Society, I mean, they've just announced yet another male president. And so my view is, well, then they just aren't listening. And they're just not paying attention to who makes up the Heart Failure Society. So I've decided I'm not going to go to the meeting. And I think that if it's bothering other people, then they should either speak up and talk about it and make sure that they say something about it, or they tell people why they're not going to go. I do think that for microaggressions and other things, you have to learn to be able to say, no, you can't do that. No, that's not a way to speak to me. And I think we also have to lead by example. I mean, all of you are being very kind and addressing me as Dr. Jessup. And one of the things that always happens on a panel is everybody else is doctor, and then they get to the woman and they say Mariell. And there are all kinds of things like that. I think that the best we can do is ignore it. And when you can't ignore it anymore, you just need to say something, but you need to say something in a constructive way, quietly maybe, or just out loud. And I've been known to say things out loud. And in fact, I was just on an earlier call, and last week at a scientific meeting, a new surgical implant was described, and it was all very exciting. And the study was in India. And all 12 of the steering committee were men. They showed the pictures. And then, as opposed to all other valve trials, 60% were women who they described as needing this valve because they were poorly compliant with anticoagulation or they wanted to get pregnant. And they had some complications in the trial. And I just sat there and thought, I can't believe this trial. I think it was unethical that there were 12 men, and this was done in India, where they said, well, it's a very, it's a third world country. And they were doing this brand new valve, and not one person was a woman that was considering these women and what their options were. So I said something to the presenter of the trial, and I said something to one of the organizers of the meeting. And then they showed up on yet another committee I'm on, and I made sure people knew about it. So there's certain things you just can't ignore. There's certain things that are not appropriate. But there are many things that you just have to hold your head up and model good behavior.
Thank you, Dr. Jessup, for sharing your insights and wisdom and experiences. I really like the point you made about leading by example for those around us and speaking up in constructive ways. And Dr. Reza, I want to turn it over to you to ask, how do you think programs can support women fellows and women trainees more intentionally, especially those considering advanced heart failure and transplant cardiology, which may be perceived as a more intense field?
Thanks, Carleen. Yeah, there's so much work to be done here. And I think what I and many others have been working on recently, obviously inspired by everything Dr. Jessup just talked about, is really lowering the activation energy to make some of these changes, really putting on display that it's not really anything that takes a lot of effort or a lot of human power. These changes can be made very deliberately, and even things that may be perceived as quote unquote small can have outsized and very large impact. And so ultimately, programs should be proactive and not passive in creating inclusive environments. I think historically, these efforts have been at the grassroots level or homegrown or coming from trainees, but there's no reason, I think, in 2025 that needs to happen anymore. These initiatives can be and should be led by program leadership. That starts with recognizing, for example, these perceptions, as you mentioned, of heart failure cardiology or cardiology broadly, but specifically potentially heart failure cardiology as high burnout, high intensity, often things we hear about the practice of heart failure in the contemporary day and age, which may deter women and men, but here we're talking about women from pursuing this kind of field. And so again, investing in efforts like role modeling, early exposure, some evidence-based strategies that I and others, in fact, a mentee of mine at the University of Pennsylvania recently published in the Journal of Cardiac Failure. Visibility matters. So seeing women thrive in heart failure careers can help dispel those myths. So things that programs can do, for example, are putting their heart failure cardiologists who happen to be women in front of trainees, whether it's having them rotate with them on inpatient services, having them come give talks. One thing to do is really just audit your didactic curriculum and see, is there adequate and equitable gender and sex representation represented by the people who are speaking to your fellows and role modeling in front of your fellows? And then there are, of course, systemic barriers that go beyond what a training program can do. And those things are related to career flexibility, support for family planning, and culturally competent mentorship, pay equity. But I would argue even these things that are sort of historically thought to be out of scope of a training program in this day and age are very much in scope. And these changes can come from the nucleus of a fellowship and a training program asking for and driving that change. And I think these are non-negotiables in my perspective if we want a diverse and sustainable workforce.
Thank you, Dr. Reza, for sharing those very actionable points. I think we often talk loosely about ways to be more inclusive, but I like the concrete ways that you mentioned that programs can take, such as making women leaders visible to trainees. And I think a lot of times when we hear about career development, we think about mentorship, and it clearly plays a really pivotal role in retaining women in cardiology and in heart failures. And mentorship can offer guidance and advice and really allow for professional growth. But mentorship alone isn't enough. Sponsorship is also an important aspect. And a sponsor might be someone who's actively advocating for you when you're not in the room, or can use their influence to open doors and opportunities and help advance careers in tangible ways. Can you speak, both Dr. Reza and Dr. Jessup, to the importance of sponsorship and perhaps share any stories where it changed your trajectory?
Well, I can jump in initially because in my role at the AHA, I think the sponsorship is key. I mean, there's so many people that want to have a role. And many times people will say to me, well, who of this whole list can we put up for this role in heart failure or transplant? And I know a lot of people, but I don't know everybody. And if somebody hasn't bothered to come up and introduce themselves to me and said, here's what I'm doing, this is what I want to do, I'm very interested, I like this, I'm studying that, sending me a follow-up note, there are very few women that do that. And if I could tell you how many men do it, you'd be surprised. So I think if you want somebody to sponsor, again, you need to do a little extra. And when there's people that you know that are in key positions, go up. And I know one of my former colleagues, Anjali Owens, says, Mariell, people don't use cards anymore. Well, whatever you do now, if you don't have a card, go up and introduce yourself to the key people at the AHA or at every organization you're part of so that they know who you are and where you are, so that the next time somebody asks me, who of these names do you know that you could push forward, then I will know you. And I think that's, again, the situation. When you're at a meeting, make yourself go up and talk to people so they'll remember who you are. And people will then remember your name and sponsor you. So sponsorship is really, really key. The other part of sponsorship is if somebody gives your name and then you say no too many times, and there's lots of reasons why you have to say no, you need to follow up with that person and say, I'm so pleased that you put my name forward. And I've had to say no for the following X and Y reason, but don't let them give up on you.
And I'll jump in to say sponsorship has made an enormous difference and impact in my career. Dr. Jessup herself was actually one of my earliest sponsors. She offered me opportunities to write with her high impact reviews and editorials when I was just starting to explore a career in clinical investigation. And the skills that I learned in written communication through mentorship and sponsorship with her really ignited my fire to continue writing and doing research in the subsequent years. And already in my early career, I have countless moments that I could describe where senior leaders, both women and men, put my name forward for writing groups, speaker invitations, leadership roles, and many of these opportunities ultimately accelerated my career trajectory beyond what I would ever be able to accomplish without that kind of support. Being mentored by Dr. Jessup, as you can tell, means that I know to underpromise and overdeliver, and so that's something that I always strive to do. And you asked about a potential example that I could share in which sponsorship made a difference, and I would actually give you a recent example of Dr. Amit Goyal of CardioNerds Origin and Fame. He actually nominated me for the Women as One Escalator Award last year. And I was fortunate enough to be one of the 7 winners of that award, which led to several opportunities and connections in the world of cardiovascular clinical trials. So we need to make these opportunities more transparent and ensure that women are not overlooked for high profile and career defining roles, and help women build these networks and relationships that ultimately do result and spawn these sponsorship opportunities.
Thank you both for sharing your stories. Let's shift gears. Representation isn't just a pipeline issue, it impacts how we care for our patients. How does having more women in heart failure leadership influence patient care, clinical trial design, or even the types of research questions we prioritize?
Well, I think that there's an accumulating body of evidence to suggest that women are more empathetic with patients. And by, I would assume, gaining more information by listening better, by eliciting more pertinent history, that they end up doing a better job taking care of that patient. I'm not aware that there's much data about that in heart failure specifically, but there are in many other areas of cardiology, especially in the emergency room and acute coronary syndrome. So, if any of you know that there's data specifically in the heart failure world, I'd be interested to know. I think if we are ever going to get enough women in heart failure trials, the data does show over and over that women, if there are women on the steering committee, except in India, apparently, if there's women on the steering committee, then there's more likely to be women that get enrolled in the trial. And so I think lots of people make that assumption, and there's good data to suggest it. The question is, what are the specific steps that get having women on the steering committee? How does that translate into getting more women enrolled? Is it that they're intimately involved in recruiting women, or that somehow the trial is designed to accommodate women? I think those are the kinds of things we still don't know yet. People are beginning to tease that out.
Yeah, I completely agree. I will say this is really where representation doesn't just matter in the abstract, it affects the very care that we deliver to our patients. One of my earliest research efforts in this space was actually a question that I came up with, mentored by Dr. Jessup, and it was a study that we published in Circulation Heart Failure in 2020, where we examined gender disparities in the authorship of heart failure guidelines and clinical trials. And I think it was that study, Dr. Jessup can correct me if I'm wrong, but I believe that we found for the first time that heart failure trials who had a women first or senior author was associated with, as she mentioned, a higher proportion of enrolled female participants. And then this finding was subsequently confirmed by other investigators, both within heart failure and other cardiovascular disciplines. Our work went on to be cited in, for example, major heart failure journals, new diversity policies with regards to their authorship, inspired efforts to diversify journal editorial boards and the research that journals accepted. So I think it was, and I hope that was widely impactful. And then subsequent studies have shown that trials led by women investigators, as Dr. Jessup said, enroll a greater proportion of participants who are actually historically underrepresented and excluded from cardiovascular care. These trials also generate better evidence to assess for sex and race or ethnicity differences as effects or modifiers of interventions, which are all crucial needs for the advancement of the science that we're talking about. So ultimately, when women are at the table, we see broader, more inclusive research questions asked. We see more inclusive clinical trial enrollment. We see care models designed that center the lived experience of patients and incorporate some of the things you just heard Dr. Jessup say with regards to being of childbearing age and being historically excluded from participation in clinical trials, for example. So increasing gender diversity in leadership really helps challenge all of these gaps and ensures that we're designing research and care systems that ultimately reflect the populations that we serve.
Outstanding. Thank you both. That was really wonderful. I think that there's an incredible amount to be hopeful about in our field. And so I think we wanted to ask you, when you envision kind of the next 10 years when it comes to gender equity and heart failure cardiology, what do you see and what do you hope for?
Well, I'm very hopeful. I think things have come a really long way. And I mentioned earlier, and it is really true, I am asked almost on, if not daily basis, weekly basis, I need some women to speak or to be on this committee or to be on this trial. I mean, that people are actively looking. And I think that that is a really noticeable change. Even at TCT, a notorious male-dominated meeting, they go out of their way now to make sure there's women on every panel, and they take it seriously and they point it out. They're so proud. It is great. I think the AHA, ACC, and now even ESC, which was also just a total male bastion, now really go out of their way to make sure women are on every panel and on every committee. So I think things have changed dramatically and very much so. What I see in the future is concern about the role of the caring, practicing heart failure transplant physician. I worry that the number of skills and knowledge base that somebody has to maintain to do all of that, as opposed to, I'm just a transplant doctor, or I'm just a bad doctor, or I'm a heart failure doctor, which I understand why that's happening. I worry that the people won't exist anymore that can really look at this in a broader way of saying what's the right thing for each one of the patients. But that's a small concern because it means we've gotten past all of the other truly annoying problems. So I'm very bullish about the future. I think our field of heart failure and transplant is still an important one. It's acknowledged as an important part of all of cardiology. I think we're going to have to adapt a little bit. We may need to adapt the training of heart failure transplant doctors. Not everybody wants to learn about transplant, that they want to go and do inherited cardiomyopathies, for example, or gene therapy. And so do we really need everybody to learn about VADS and transplant if they really want to go on and do something very specific? So we have to answer those kinds of questions pretty soon about what are we going to do with training and how is it that we're going to get people to continue to come into our field. We have to be adaptable and flexible. So I'm hoping we'll talk about that in the future and not so much about disparities of training and inclusivity of everyone into our field.
I completely agree. I would say what gives me hope are conversations like these. This momentum that I see among cardiologists across identity, across career stage, who are pushing for change, calling for personal and systemic accountability, and pursuing leadership positions, ultimately to have impacts and move the needle in these areas is really inspiring. I think we're no longer afraid to have these conversations very openly with large audiences and big platforms. Shout out to CardioNerds. And we're creating communities of support that didn't exist even a decade ago, much less 2 or 3 decades ago. So I completely agree with Dr. Jessup that my hope is that in 10 years, we actually won't be having this conversation. We won't be talking about representation as a deficit, and that we'll be at a place that everyone knows and truly believes in the dividends of inclusion, innovation, and excellence that comes from having a truly diverse workforce. And we can get on to the hard and important work of providing the best possible care for our patients.
Thank you so much, Dr. Jessup and Dr. Reza, for taking time to share your insights with us today. It's been so great to learn from your stories and experiences and wisdom. And as trainees, we're so grateful for everything you've done for the field and the way you continue to role model leadership and inclusiveness. And a question that we always ask everyone on CardioNerds is, what makes your heart flutter? So for you guys, what makes your heart flutter when it comes to women leading the change in advanced heart failure?
Oh, I'm incredibly lucky to have the role at the American Heart Association that I do. And almost every day there's something that gives me a flutter. I love seeing my mentees stand up and give this great lecture and do a terrific job. And that thrills me beyond words. I love when I see a woman lead a group and really chart new pathways in our field, and they do it much more elegantly and humbly than I ever did anything. So I love to see women of all shapes and sizes and backgrounds flourish in their own way. So there's many, many opportunities like that to know that the future is safe and that there's going to be an ongoing march of women that are going to excel. That's what gives me my heart a flutter.
No surprise, I completely agree. It's seeing women not just survive in this field, but thrive and lead. So it's seeing Gurleen publish yet another amazing paper in the world of cardiovascular prevention, knowing that Jenna is about to become the director of a clinical program in her first year on faculty. Apurva, I'm sure there's many amazing things in your future. The light at the end of the tunnel, it comes sooner than you think. But all of this, and of course, I would say most of all, my patients telling me that they're so happy to have a woman cardiologist. But it's that sense of collective assent. It reminds me that we're not just filling seats at a table, we're designing a new room where everyone belongs.
Thank you both, Dr. Jessup, Dr. Reza, for sharing your wisdom, your stories, and your vision for a more equitable future in heart failure cardiology. And to our listeners, thanks for tuning in to this episode of CardioNerds, the first of a collaborative series with the AHA WIC Committee. We hope this episode inspires you to champion equity, mentorship, and representation wherever you are in your journey.
Thank you so much for tuning into this CardioNerds episode. The audio editing for this episode was performed by me, Grace Chu. I'm an intern in the CardioNerds Academy, House Jones, and medical student at Thomas Jefferson University. Check out the episode page for show notes and references. If you found this episode or show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episode. And now, my friends, it's time to make like an S2 and split.